You managed to log in? Okay. Yeah, I'll just give you permission. It will come. Yeah, yeah, you're with us. I can see you. Okay, so best thing is now to just share your desktop with us. Yeah, fantastic. So we've got 2 more minutes. So just give me a second. I'll introduce you in a second. Your last lecture was very well received. I've got some very, very good comments about your lecture.
Oh, all right. Well, that's very good to know.
Yeah, no, very good feedback actually. And a lot of people in the US were asking us to do some more discussions, which hopefully we'll try and set up in another meeting. So
Okay.
they've written some suggestions of discussion which they wanted us to do.
Yeah.
So we'll do that in another meeting, I said. So no, very, very good reviews actually.
Oh, thank you. Thank you. I'm pleased to know. You know, if
Oh,
you put this, if people find it useful, only then is our
no,
objective.
people are definitely, I mean, it's all about interaction and making sure that we communicate the message to the people. So that's the interaction is also very important. I hope Kamran also logs in today. I hope he's got time. I don't know if he's got time.
Yeah, we had a brief chat yesterday, and he thought he was helping for a case, and but he said he will join in. It wasn't his case, but he was going to help a colleague, so he said he should be able to come and join us
On a Sunday.
on a Sunday. Yeah. So it was some urgent case that they had to do.
Yeah. You guys need to learn to chill, man. But I think you're a young surgeon, so it's good you're doing all this thing. I've done my fair share, so now
Yeah.
Yeah. Okay, so we are 5 o'clock. Let me just start the recording. Okay, good evening, ladies and gentlemen. Welcome once again to another session of Thoracic Gurus. In fact, it's more like cardiothoracic gurus. And I'm again very pleased to invite to the forum Mr. Asghar Nawaz, who's a consultant cardiothoracic, robotic and transplant surgeon at Mater Misericordia University Hospital, Dublin. And he's going to talk to us today about lung volume reduction surgery. As you're aware, Mr. Nawaz, the audience is a group of exam going and residents and senior and junior surgeons who are who are looking for guidance. This is a very important topic because it again features in all parts of the discussion, particularly in the FRCS exams. So take it away, Asghar. Do your slides, and then we'll have a discussion at the end on certain points. Thank you very much once again for your contribution.
Okay, thank you once again for the invitation and your kind introduction. And hello, everyone, wherever is listening to me. I got feedback, and I hope that you will enjoy this session today as well. And as Mr. Khan said, it's one of the very important and interesting topics as well that we are going to discuss today. And this is called the lung volume reduction surgery. Now, personally, I feel LVRS is an operation where I actually make the patient feel better as compared to, when patient come for, say, for example, lung surgery and we do the lung resection. Functionally, we we leave them with less lung, and their capacity may be not as good. But this operation is completely different. But having said that, although this is technically, again, this is according to me, technically a relatively easy operation to do, but the case selection and the overall management of a patient requiring lung volume reduction surgery is quite laborious, and we will see, during our discussion. So always just to discuss a little bit about the history of lung volume reduction surgery, I divide this into 3 eras. And this is not a new operation, it has been there for a while, and early introduction was in early 1950s. And pneumectomy, which is called the non-anatomical resection of the emphysematous lung by thoracotomy to palliate the chronic dyspnea, was proposed and tested by Otto Brentigan in 1950s. While the physiologic principles of the procedure appeared to be beneficial and the patient had symptomatic improvement, but the operative morbidity and the mortality, both, they proved to be prohibitive. And that relegated the procedure to the obscure pages of the history of surgery for emphysema. And where it laid alongside the other procedures, which I never heard of even during my, never seen during my training period, called costochondrectomy, phrenic nerve lysis, or glumectomy for the lung volume reduction surgery itself. Okay, we have seen the phrenic nerve lysis, but not for the lung volume reduction surgery. Then Joel Cooper and the colleagues, what I call is, they resurrected the concept of partial pneumectomy about 4 decades later, advocating the bilateral non-anatomic stapled resection through a median sternotomy, yielding a considerable reduction in the operative morbidity and the mortality, and the lung volume reduction surgery was kind of reborn. And the operative mortality, although it was reduced, but it varied substantially between 2.5 to about 10%. And the Medicare patients in US having the lung volume reduction surgery between October 99 and 96 revealed a rather bleaker picture with 90-day mortality of about 14.4%. And then there is an era which everyone among us knows, and that era is called the net trial era, where the specific team approach was designed to work out further the lung volume reduction surgery. And today's most of our discussion will be around the net, or based on the net findings. Now let's define what the COPD itself is, what the emphysema it is. It's all basics back to medical school. According to the World Health Organization, the chronic obstruction of the lung airflow that interferes with normal breathing and is not fully reversible. That's the definition of the COPD. The specific cutoff point for this definition is based on the spirometric findings, and that is calculated by the ratio of FEV1 to FVC. And if that is less than 0.7, then that defines your COPD. But COPD is a spectrum of disease which encompasses some other disease processes, such as the emphysema. The emphysema is, as you can see on the slide, the abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, which results in a decrease in the elastic recoil, a decreased expiratory flow rate, hyperinflation, and as a result, air trapping. Now, when you are discussing cases with your chest physicians, if you use their terminology, well, then they like you. But gold is not only the terminology for the physicians, it's used very widely. And gold stands for Global Initiative for Chronic Obstructive Lung Disease. And they have divided the severity, the COPD according to its severity between mild, moderate, severe, and very severe. And that is based on, again, the spirometric values where airflow limitation is measured and is expressed as a percentage of the predicted. The gold classification correlates the lung with the mortality as well as the infective exacerbations of the COPD as well. And as I said, it is very widely used in guidelines, is also used in the NICE guidelines when they define it. And for us as surgeons, I would say it's important to know the gold 1 is anything which is equivalent or more than 80% of the predicted FEV1. And the gold 4, which is very severe form, it is FEV1 of less than 30% or less than 50% for people who have a chronic respiratory failure. So if you look onto the WHO database regarding the global burden of this disease, you actually find out that this is quite prevalent and is the 5th leading cause of the death worldwide. There are about 251 million cases of COPD globally, according to the data of WHO in 2016. And in the US and UK, this is probably the 4th leading cause of the death in patients. There are about estimated 3 million people affected in the UK from this, but having said that, some data also suggests that there are further 2 million people which remain underdiagnosed, but potentially likely to have COPD. And another important thing which I extracted from the WHO data is also that more than 90% of the COPD deaths occur in the low as well as middle income countries. So that my colleagues in India and Pakistan are that part of the world who are relatively underdeveloped countries economically, they can understand that this disease is quite prevalent in their regions as well. And the primary cause for this is obviously tobacco smoking, although there could be other pollutions causing this phenomenon as well. Now, the COPD is not curable, but it is preventable, it is treatable. And the first line of treatment for this is the medical treatment. And what the medical treatment aims to achieve is to minimize the airflow limitation and also to improve the functional capacity so that the patient can get a reasonable quality of life. And how do we achieve that? The first and foremost important thing which comes in this is the removing the causative factor, which is smoking. So smoking cessation has got a really, really significant role to play when you are having conversation with the patient. Although as surgeons, we don't get involved in that part of the discussion, but remember, we always have to remind our patients that they need to stop away from the smoking. They need to get the respiratory muscle training through the physiotherapy they need to also look at their nutrition. Now, they might need input from the dietitian, because if the patients are very obese, where their body mass index is quite significantly high, putting them into the morbid obesity, they need to reduce weight. On the other hand, the group of patients who are malnutrited or undernutrited, they then need to be fed, given the calories, improve the diet so they can get this strength. And there is also psychosocial training required for this as well. In terms of pharmacotherapy, the medications are, there is a list of inhalers, nebulizers, and all those. The physicians usually deal with that, and we're going to skip them. But what I wanted to tell here is that the smoking cessation and the pulmonary rehabilitation are very important things for the management of these patients. And when they get referred to us, then we need to also emphasize that these patients have gone through this and they understand the importance of these. Otherwise, we will need to manage that patient slightly differently. Medical management may also include giving some vaccinations like flu vaccine in winter season, like we get in the United Kingdom, or use of the pneumococcal vaccines, the use of antibiotics. And when the disease is at later stages, they may require steroids or long-term oxygen therapy. When it comes to the interventions, so I'm using the word interventions here, not the operations, then there are a few ways where we can help these patients. This is where our role comes into play. And this only comes in when all the above, which I've just discussed in the previous slides, have taken place and have been addressed both by our referring physician as well as by the patient himself. These patients need to have at least 6 months of smoking cessation. And the medical treatment should have been exhausted before we consider intervention. Obviously, there will be some exceptional cases where we might need to intervene early. Now, what are these interventions? Now, they could be bronchoscopic interventions, or this could be a surgical lung volume reduction. If we speak about the bronchoscopic intervention, there are a variety of these available now. Most of these are, although done by our interventional pulmonologists, but at the same time, there are quite a few thoracic surgeons who also do bronchoscopic intervention. So it's important for us to understand these interventions and learn these skills. They're not difficult because we're always dealing with the airway anyway, and it's just a going little extra mile to learn these. If your system, if your trust, if your hospital allows you that kind of practice and you have got the facilities and interest into this particular part. Now, these bronchoscopic interventions could be in the form of endobronchial valves or endobronchial occlusions by the coils or the plugs, or this could be extra anatomic bypass of the bronchus, or the thermal ablation. On the other hand, the surgery encompasses what we call as surgical lung volume reduction. Now, this could be carried out, as you could see here, through an open procedure or through the VATS in malaxis. Open ways of doing it is through median sternotomy and thoracotomy, and VATS or robotic is the alternate. There are some other procedures which I mentioned earlier on as well, which are quite obsolete. There is a list of these, I've mentioned them before. The further in that list also includes the radical hilar denervation, the thoracoplasty. They are very rarely done nowadays. So what do we want to achieve when we do lung volume reduction surgery? And I will give the reference of the Dr. Brentigan in a journal which he published in 1957. And he says an operation directed at restoring the normal physiology rather than removing pathological tissue. and resection of the functionally useless emphysematous lung, thus reducing volume to equal the pleural capacity in full expiration. That's what we are going to achieve. And that's what our main purpose is by doing this operation. And this objective of long volume reduction surgery is the safe, effective, and durable palliation of dyspnea in appropriately selected patients with moderate to severe emphysema. Now, long volume reduction surgery for your exam purposes, when it comes to discussion, what do you want to achieve, or the hypothesized benefits includes the improvement of VQ mismatch, which happens if you don't treat in these patients, regain the diaphragm and chest wall functionality, expansion of the normal compressed lung tissue, because when the disease part is removed, then the normal part gets some space and participates in the phenomena of gas exchange. It also increases the exercise capacity of the patient, and it decreases the hypoxemia and hypercapnia, and also it has effect onto the cardiac function as well. It reduces the RV hypertrophy. It also improves the LV function as well. Now, let's discuss what is the base on which our whole LVRS program is based on, and this is called a randomized control trial, NET trial. Everyone who is going to be sitting in the exam really need to be aware of this this trial. It is quite a milestone in the surgery for emphysema and COPD. If you get a case like a long case, a short case, you will be expected to know, because all your management really goes around the findings which we discovered from the NET trial. This trial was conducted in the US, North America in 1998 to 2002. It randomized 1,218 patients. It was a multi-center trial. It was conducted in 17 centers. Basically, the purpose of the trial was to, as we said, the Joel Cooper's operation, and to see whether these operations were really giving benefits to the patient. So the primary objective was to determine the role and safety and effectiveness of the bilateral LVRS. And this secondary objective was also to identify patients who would potentially benefit from it. Now, the criteria for these included severe COPD patients, and it was defined as FEV1 of less than 45% and hyperinflation. And that hyperinflation was then had a parameter to assess, that was through the plethysmography. This included the residual volume of more than 150%. These patients had a median follow-up of 4 years. And this trial findings were then published in the New England Journal of Medicine in 2003. Now, the trial basically randomized the patients into two groups. One group who underwent surgery, the other group underwent the best medical therapy. And they had equal share of the patients, 608 in the bilateral LVRS and 610 in the medical group. The surgery was performed through the median sternotomy for most of the cases, and it was bilateral stapled resection for long volume reduction surgery. And the area which they resected, that amounted about 20 to 35% of the lung volume. The best medical therapy basically required continuation of the medical treatment with the pulmonary rehab and smoking cessation. Now, the findings of these trial, which were published in the journal, that concluded that the 90-day, sorry, not 90%, 90-day mortality in the surgical group was 7.9% overall 7.9%. But this has further reduced down to 5.5% when they did the high-risk groups sub-analysis. Basically, they excluded the high-risk group, and the mortality was reduced in the overall group to 5.5%. The overall exercise tolerance improved after the lung volume reduction surgery, but only upper lobe predominance and low exercise capacity patients saw a survival benefit. And this subgroup risk ratio was 0.47, which had a significant p-value of 0.005. By 2 years, 31% still enjoyed excessive, sorry, not excessive, the exercise tolerance, which was above the baseline as compared to their other group in the medical management, which had the effect of about 10%. And the high risk group, as you can see on the slide, I would just like to tell you what the high risk group mean. The high risk group mean the people who had FEV1 of less than 20%, DLCO less than 20%, and they had a rather homogeneous pattern of the emphysema. Now, this is an interesting slide where you can see 3 pictures which show the overall all patients' mortality and morbidity, and then it also looks onto the benefits separately onto the high-risk patients and non-high-risk patients. So overall, the 90% mortality in the surgery group was 7.9%. And this was significantly higher than that in the medical therapy group. And there was no significant difference in the overall mortality despite a higher early mortality rate in the surgery group. While in the high risk group, the subgroup of 140 patients, which is in picture B, with a value for FEV1 that was less than 20% or less of the predicted value, and either homogeneous emphysema, as I said before, which is, this is all high risk definition of the high risk group. They were previously reported to be at high risk of death, when Mr. Cooper was doing operation. So these patients, high risk patients, were reported to be high risk of death after lung volume reduction surgery. And during this trial, there was same observation. And interestingly, when they analyzed the non-high risk group of patients, which was 1,000 and remaining 1,078 patients who were not at high risk, the 30-day mortality rate was 2.2%, as compared to 0.2% in the medical group. And the 90-day mortality was 5.2% in the surgery group as compared to 1.5% in the medical group. And this has quite significant p-value of 0.001. And the changes in exercise capacity, distance walked in 6 minutes, percentage of predicted value for FEV1, quality of life, degree of dyspnea, and they were all measured at 6 months, 12 months, and 24 months, and they all favored the surgery. Okay, so in the non-high risk group, mortality as well as the 6, 12, and 24 months follow-up, including the exercise capacity and symptomatic relief, they all favored the surgery. And this is what made the base for lung volume reduction surgery. Now, when we look further into the subgroup analysis, this is another finding, especially for my junior colleagues who will be appearing for the exam. This is something which will get discussed as well. So the subgroup analysis of non-high risk patients at 6, 12, and 24 months. When these patients were divided into 4 subgroups on the basis of combination of upper lobe or non-upper lobe emphysema and low or high exercise tolerance at the baseline, there was strong evidence of differential effect on the risk of death and also on the exercise capacity. So both. Among 290 patients with upper lobe, so now we are talking about the subgroup analysis. So 290 patients, which you can see in the graph, graph D. So 290 patients with upper lobe predominant disease and low exercise capacity in this subgroup of surgery had a lower risk of death than the patients in the equivalent medical therapy group. And they were more likely to have an improvement of more than 10 watt in the maximal workload. This was another thing which they measured in these patients. What was their workload, maximum workload in terms of doing exercise? So they noted the improvement of 10 watts. And these patients were also likely, because they also developed some questionnaire to measure the quality of life of these patients. And these were more likely to have 8-point improvement in the St. George's Respiratory Questionnaire, which was filled in at the end of the 2 years for all these patients. Now, in conclusion, although the high risk group, which has lower FEV1 and DLCO with homogeneous emphysema, had a higher mortality and lower functional benefit from lung volume reduction surgery. On the contrary, the patients with predominantly upper lobe emphysema and low workload or low exercise capacity after the the routine rehabilitation, they showed a greater probability of improvement in the exercise capacity, greater probability of improvement in the symptoms, and especially if they underwent the lung volume reduction surgery. Okay, so this is the main theme of this whole trial. If you want to just say in one sentence that upper lobe predominant heterogeneous emphysema in patients who had low exercise capacity benefited the most with the surgical resection. Okay. So that's the conclusion of the trial, which was published in the journal. I'll just read it for you. It says overall lung volume reduction surgery increases the chance of improved exercise capacity, but does not confer a survival advantage over medical therapy. It does yield a survival advantage for patients with both predominant upper lobe emphysema and low baseline exercise capacity. Patients previously reported to be a high risk, those with non-upper lobe emphysema and higher baseline capacity are poor candidates for LVRS because of the increased mortality and negligible functional gain. Okay, so now let's move to we have looked on to what the trial showed us. And now we need to see how we are going to, in our practical life, how we are going to work out these patients, how we are going to assess these patients, and who we are going to offer the surgery in our clinical practice. Now, as you can see, I have put some inclusion and exclusion criteria here. And As I said in the very beginning, the patient selection, I will emphasize again, the patient selection is the most important and most challenging in the management of the COPD and emphysema patients. Remember this, please. And it plays a crucial role on the successful outcome and also your results as well. So you have to choose those patients which will potentially benefit from these, and you know from from the trial that this is upper lobe predominant heterogeneous group with low exercise capacity. Okay, I'm reminding this message again and again so that from this today's talk, at least our juniors take this message home. Now you will like to offer these patients to patients who have got some reasonable prognosis. Relatively younger group, I don't know, I mean, and the 75 basically comes into the middle-aged group by definition in the Western world. It may be slightly different onto the Indian population, but usually you tend to offer surgery younger than 75 years of age. And also the patient should be educated and he should have reasonable expectation from what benefits he is going to achieve from this operation. This patient needs to be really symptomatic. And that's what the definition of low exercise capacity is. And if you scientifically try to define it, we have got our dyspnea scale, the latest of which is the modified dyspnea scale, MRC scale. And the score for this needs to be 3, at least, 4 better, 3 to 4, and the emphysema needs to be severe emphysema. And how did you measure it? You will see clinically the hyperinflation of the chest, and you will also calculate it from the ratio of the residual volume with the total lung capacity. And if the ratio is more than 0.65, that patient is likely to benefit from it. And this, the bottom message is basically upper lobe emphysema with low exercise capacity. Now, who would you exclude offering this surgery? That is very important. Please look at this slide. Keep these patients or these characteristics in your mind. The patients who have either inability to do the rehab, or they're not willing for the pulmonary rehab, and neither for smoking cessation, they are going to not give you good results. They're gonna, so your outcomes will not be good. So they are not your good candidates. Patients who have got characteristics of homogeneous emphysema, we know from the trial they are unlikely to benefit. Although recently I was looking onto the papers, in some selected cases, some people have done surgery, but the benefits are not really clear-cut. Okay, and you need to exclude the high-risk group. That high-risk group which was excluded in the NET trial, and this is the people who have got FEV1 of less than 20%, people who have got severely parenchymal disease. There is a huge parenchymal loss and they have a reduced diffusion capacity less than 20%. They're not the good candidates. They are a high risk group. They are likely to actually die. Very high mortality in this group. Primary pulmonary hypertension is a contraindication. So always please check the pulmonary hypertension, get the echo and get the PA pressure measured. And if it is more than 35 arterial pressure, turn them down for surgery. And patients who had either significant coronary artery disease or heart failure, or very obese, very frail, on either end of this malnutrition, or if they have got any other significant comorbidities, you really need to think very carefully whether you are going to offer them surgery or not. I put an additional thing here. People say for previous thoracotomy or pleurodesis. This is also exclusion criteria. I actually do agree with this because, as you will see further on in our discussion, these are very complex patients, and the surgery is slightly technically you have to do some slightly different maneuver. And if these patient doesn't have a good lung parenchyma with pleurodesis, whatever sort of pleurodesis they had before, it is very likely that they will have lungs stuck to the chest wall. You will then be scratching your head afterwards because these patients will have prolonged significant air leak. So this, to my eyes, is a contraindication. We'll see what Mr. Khan or our other colleagues think about this. Consider all the, this is the few points which I mentioned here, but you need to consider the overall picture of the patient. And that overall picture comes from the anatomical effects as well as the physiological effects of the patient, and then the further investigations in the form of CT and VQ scan and lung function testing. There is also another test, which is not very commonly used, but some centers who have the facility do use it. It's called the VQ scanning, and they have got a physiological assessment by the Q score. They usually use it for the assessment of these patients. What is Q score? Basically is the assessment of heterogeneity or the quantification of heterogeneity based on the VQ scan. There is a target zone. So basically you calculate the ratio of target zone to the total lung perfusion. And if the score is less than 10%, then surgery could be offered to these patients. Patient with target areas in the upper lobe can potentially be included. Sorry, not the upper lobe will definitely be included. The patient in the lower lobe, heterogeneous, can potentially, as I said, be included for the surgery, but you have to have discussion with these patients and tell them, counsel them appropriately about the reduced benefits according to the NET trial results. Indications is basically, we have already discussed all this. It's a repetition. So severe symptomatic patients with severe emphysema, bilateral, heterogeneous, where you have surgically accessible target areas. And prior to that, they need to have smoking cessation, although I've written here 4 months prior. 4 months prior is mandatory, but at least it should be, normally we say 6 months before we offer the surgery. Their 6-minute walk test, because these patients would have gone through the pulmonary rehab, should be above 140 meters. The FEV1 should lie between 20 to 45%. Because if it is less than 20%, then we know from the NET trial as a high-risk patient, we will have higher mortality or significant comorbidities with that. On the other hand, patients who have got more than 50%, FEV1 more than 50%, they may not be that unwell to go for surgery, excluding in certain circumstances. The total lung capacity should be double, more than 100%, and they need to have residual lung volume more than 150%. This is calculated through their body plethysmography. The CO2 less than 60 millimeter of mercury and PO2 more than 45 on room air. Now, all these such cases, although we have discussed the inclusion criteria, we have discussed the exclusion criteria, we discussed the trial findings, then I put this separately as indication for lung volume reduction surgery. Still, these patients need to be discussed specifically at the emphysema MDT. And all these patients need to have, optimization beforehand, as we discussed. They need to have the maximum treatment of medical management, whatever needs to be done. And if they are on steroids, Now, this will show that the patient is at a higher end of requiring this treatment, but at the same time, pay particular attention to your steroids. And if possible, have a discussion with your referring chest physician, get them wean and either wean off or reduced if possible, at least wean off, because they have significant effect in the recovery of these patients. And weight is an important thing. It may not be easy thing for these patients when you ask them to reduce the weight because they're already struggling patients, but you still need to encourage them to reduce the weight if they are significant morbidity. On the other hand, frail patients need to get some strength so that they can cope the catabolic process which goes through their body when they are going for the surgery. And when these patients are referred to you for surgery, assess them. They have been optimized fully. Now you need to assess them. And that assessment, you need to have a criteria, how you assess them. And that assessment will be from these tests which you have done, as well as the questionnaire which I was mentioning to you earlier on. There are two specific questionnaires which people use for these kind of patients. One is the short form 36, SF36 form. You can get it online. And there is also a Euro-Qual questionnaire, Euro Quality questionnaire. If you get these, then you will know this is a survey which patient will actually fill in how their symptoms are, what they feel, what they can do, what they cannot do. And once you have done the surgery, then you need to reassess them and see how much benefit they have got. I think it is important to consider it because you need to know how many patients are benefiting from this surgery. And if they are not, maybe you need to relook at your selection, or maybe they need to have further proper optimization before they come to you for surgery. As I said before, chest physician is your best friend. If they are not, make them friend, okay? These are very complex patients. In fact, chest physician will be looking for a good thoracic surgeon because they themselves are gone through all the options and they have no other way to help these patients. But you still need to keep them on your side as well, because this patient management is quite complex and you need their help, you need their involvement throughout the process, prior to this and in the selection process and following the operation as well. And I suppose, in my eyes, the emphysema MDT is crucial for the successful setup as well as running of the LVRS program in any unit. The MDT, what will MDT give you? What will MDT include? It will be thoracic surgeon, it will be definitely a radiologist, it will be the chest physician, and if you have a separate interventional pulmonologist who does endobronchial valves, he should be, and you will have a specific nurse. I'm not aware of the individual countries' setups for this, but in UK and Ireland we do see we have got nurse practitioners. I suppose there are more and more of these people coming into practice. We have got the physician assistant as well. So they can be part of your MDT who will help you in running this service. And the borderline cases can be sorted for combined approach, because you will have one very straightforward case. Okay, we're going to do the valve in this patient. Then you will have, okay, this candidate fits the criteria for surgical lung volume reduction. But then there will be some borderline cases where you may be, okay, either this might help, we can put valve, we could do VATS and surgical resection. You could actually take it as a combined procedure. I mean, during my rotation days, I worked in a center where we were actually managing these patients as a combined, we were going to the interventional pulmonologist when he had a list, to help him if he required our intervention or if he required our expertise there. And sometimes he would pop in when he was referring patients for LVRS as well. And as a result, you could discuss with each other. And MDT gives you a forum to select these patients, to assess these patients. These patients would require the high resolution CT scan, and they can be reviewed by your radiologist who will have expertise in the emphysema. He could, for you, chart out the upper lobe predominance, although it is easy to see by yourself with experience. You will be able to assess the fissure completeness, which plays a significant role, especially when you're offering the endobronchial valves to these patients, because they play a part in the phenomena of what is called the collateral ventilation. The outcome of the LVRS program just does not depend on to the surgical technique only. It depends on to the whole process. And in the whole process, the optimization is really the foremost important thing, and then the selection. And the case selection and workup should be done by the dedicated MDT if it is available, if your circumstances allow. And it will be really invaluable, integral in the successful running of your LVRS program. Following the NET trial, there was initial, and why I'm saying this, following the NET trial, there was initially, because everyone knew that, oh, LVRS is useful. Everyone, whoever routinely was not doing thoracic surgery or lung resections, they looked at the trial findings, they just went in, did the operations. So they were qualified surgeons, but they were probably not experienced enough into these sort of operations. And also that affected the outcomes as well. And it led to the higher complication rate. And that's why I'm trying to put more emphasis onto the MDT and your selection and how you do your operation. If you want to look at what this LVRS pathway, this I understand does not exist in every center, but there are certain specific centers who offer lung volume reduction surgery. They follow usually this pathway of referral, where a chest physician will refer them to a surgeon or specific respiratory physician or interventional pulmonologist for the outpatient review. You will have patient clinical assessment on the history examination, and then you will have your certain tests, which will include your lung function test. This should include the patient ABGs. They should include patient's high resolution CT scan. And if there is a reason and availability of a perfusion scan, that will be useful as well. But if it is not, you could still work out around the rest of the investigations. The MDT would then discuss this patient and sort out who is suitable and who is not suitable. That's the purpose of the MDT as well. Following this, these patients will be seen in, from the point of view of offering the surgery. When they get shortlisted for surgical resection, they will be seen in the thoracic surgery outpatients. By that time, these patients should have completed their pulmonary rehab. They should have been away from their smoking. You have a discussion with the patient, you tell them the risks, you tell them the benefits, you tell them the mortality after you have gone through all the patient characteristics, and then see what patient choices. Because remember, earlier on we said patient expectation. So, and tell them about the possible complications which are likely to happen. And another thing is how long they will get this benefit for as well. So all these things need to be discussed with the patient. If the patient declines surgery, by all means, don't try to convince them. It is their right to make a decision On the other hand, if the patient is suitable and keen to go ahead for the lung volume reduction, then you offer them either the LVRS or you do the Chartis assessment to show the suitability for endobronchial intervention. For the LVRS and for the endobronchial intervention, there is a way of assessing these patients whether they will get benefit from the endobronchial intervention, and that is done usually through the Chartis assessment. Although you will have an idea even before doing the Chartis assessment whether this patient will be suitable or not, and that will be from, as I said, from your high resolution CT scan. And how can you do the surgery? There are ways of doing the surgery. Obviously, in the NET trial, most of the patients underwent median sternotomy. Some people have previously done thoracotomy for this surgery. It is relatively rare now. The most common ways of offering the surgery is minimal access, mostly through the VATS, and it's also being done through the robotic. And I think the median sternotomy and thoracotomy should be out of practice. I don't think these patients deserve to go through these kind of approaches, specifically for the LVRS, when we have trained people in the minimal access surgery. So for the people who are junior colleagues, I'll tell you, as I said, in the trial itself, there was about 70% of people who underwent bilateral LVRS through the sternotomy. And our UK database, which was analyzed previously in 2011, even at that time, we saw 41% of the LVRS were done through the sternotomy. So there was a gradual move, and now is, I would say, is almost equally non-existing. So in my eyes, VATS is the gold standard for this. Again, it is not in the guideline, it's just my personal saying in this, but I suppose most of my colleagues will agree with this. Now, VATS could be done with the 3 ports, or it could be done uniportal. We can have a debate here. If you're trained thoracic surgeon who could do VATS and uniportal VATS, I personally feel that uniportal for this particular group will be more useful, maybe more useful. And there are reasons for this, because this is doable, because we have trained people. It is comfortable for the patient, and there is a pain. Usually, we know that thoracotomy is more painful than sternotomy, and the reason for this is intercostal nerves. And if you go into multiple spaces, if you're levering onto the intercostal nerve, then you're likely to get pain from this. So pain control is important for the good recovery of these patients, and that's why I'm saying to do the uniportal. And I would suggest, even when you're doing uniportal VATS, use your preemptive analgesic technique. That could be use of local, and then in the intercostal block, or if you're sometimes in some centers, the anesthetists, they give ultrasonic, with the ultrasonic help, they give intercostal or paravertebral blocks. Some people mention epidural. I don't know whether that should be used in this, because obviously it has its own complications and risks as well. And you really want your patient to be mobilized as soon as possible. So that's why. From the uniportal, the drain can come, it will have one small hole, drain will come through the same hole. And theoretically, there are less adhesions. People who do minimal access, they say with the robot, with the VATs, adhesions are relatively less. And if you are going to intervene at one intercostal space, potentially the lung will be stuck over to that area rather than in all the areas. And this will help me or my other colleagues who do lung transplant if this patient at a later stage is considered for lung transplantation, then it makes relatively our life easy. And uniportal could be performed either through the intercostal, any of the intercostal space, fourth is usually the common space, or it could also be done through the subxiphoid. Subxiphoid will be more useful if you're going to do bilateral in the same sitting. Robotic LVRS is being done. If it could potentially be done uniportal, I haven't done it, haven't seen it, but it might be, Mr. Khan might be able to tell us if he does it or if it is possible to do it. In our center, we did a case by using the Firefly perfusion assessment, which is the intraoperative assessment by the use of intraoperative assessment for the perfusion using the ICG. So I put the video here. This is on the CTS net as well. Mr. Khan, is it okay to play it shortly?
Yeah, please carry on.
Okay. I hope it loads quick. So that's the CT scan of the patient, and that's our
You have to increase the sound on your laptop because it's not picking up on the relay.
Is the sound not coming?
No, no. You have to just increase the volume on your laptop. Have you got a headphone on by any chance, or what have you?
Yeah.
That's why it's not picking up the sound.
Slightly anterior to the scapula tip.
Yeah, now it is.
Possible to place all the ports in the same intercostal space in order to limit postoperative neuropathic pain. For the Da Vinci XI platform, the ports are sited 4 to 5 finger breadths apart in order to facilitate optimal articulation of the robotic instruments within the chest. When placing the ports, the surgeon should be cognizant that with the COPD population, the lungs may be very slow to deflate, and thus extra care needs to be taken to avoid lung injury. The remaining ports are then placed under direct vision. Care should be taken with the posterior port as the intercostal spaces are narrower. It is important to see the deep black line in the shaft in front of the port as it deconnects from the chest wall.
My suggestion is that switch off the volume of the video and you give us the commentary of what's happening. So you've got the 3 ports placed there, which we can see very clearly.
Yeah, yeah.
So
This is
is
the
an
3-port.
XI system.
This is a XI system, and after the entry port placement, this is basically the assessment of the lung that all the areas are being assessed here.
The lung doesn't look so bad, huh?
Yeah, and the interesting finding will come here is.
Would be interesting to see the CT scan of this patient, pre-op CT scan.
Yeah, it was earlier on in the at the start of the discussion, at the start of the video.
Sorry, I might have missed that. Surprisingly, the lung doesn't look that bad for as
Yes.
you would see in an LVRS patient.
Yeah, I actually agree with you. So the ICG has been given here, and now we are assessing the ventilation perfusion.
So is the ICG given intravenously or endobronchially?
Intravenously.
Okay. Both techniques are possible.
So this has a short life of 3 to 4 minutes. So you can see where the areas are green. This is the perfused areas. So this patient was a bit tricky for my colleagues. I was not involved in this case, but they basically noticed the perfusion of this is the left lung and the left upper lobe. So on this, as you could see, the lingula was actually reasonably perfused. So as a result of that assessment, the lingula was spared. And that's what basically the message wanted to give through this video, that if if you have done your assessment before, but intraoperatively, if you want further assessment, and if you have got the facility, then it can be further judged by the use of ICG. And in this particular case, as I said, the lingula seemed to be actually well perfused, and it was eventually spared, and they kind of performed the rest of, which was mostly taking the part of the upper tri segment. And now here I want to show basically this part of the video. I wanted to show to show you that how you resect the lung. This should be in specific horseshoe shape, you know, and the staple line, you need to make sure, you know, when you are stapling, depending on the quality of the lung. I actually agree with you that this does not look that bad lung, but if the lung is very bad, then you should have minimal handling, only handle that part of the lung which is going to come out, resect the horseshoe shape. And if there is a need, if the lung is too bad, if the parenchyma quality is very poor, looking at this even doesn't look too heavy smoker, although we can see the carbon in here, then you may need to use some adjuncts in addition to your resection to prevent the air leak or to minimize the air leak. Okay. So the purpose of showing this video, although you know you very rightly picked it up, this was not a strong case, but purpose was to show our audience 2 things. One, that some part of the perfusion perfusion ventilation could be assessed intraoperatively if you're doing robot. Secondly, how you do the your horseshoe shape resection. Okay. So the principles of lung volume reduction surgery. So let me just, is playing on the background still. So we want to achieve the horseshoe-shaped resection. Usually it is the upper lobe, and that's where our target areas are. But if there is any other potentially bad area, if there is a reasonable target zone, say for example in the segment 6, the apical segment of the lower lobe, that could be resected as well. But look at what the overall quality of the lung is. The chest and the diaphragm following this operation hopefully should be returning back to the anatomical or more closer to their previous anatomical position and reducing the dead space. And reducing that lung volume which we have resected will obviously increase the lateral elastic recoil of the chest wall, and it will give space to the rest of the normal lung parenchyma to expand fully. Horseshoe shape, people say, is important thing to determine. And one more message I wanted to give is please do not handle the other lung which you are not going to resect, because if you handle that lung, the quality of that lung is not good. It is likely to put you in trouble in the form of air leak. You need to aim to resect about 30%. That's the trial finding, and that's most of the surgeons do. About 30% volume of the lobe of the lung you need to resect when you're doing this sort of resection. Okay. Now, that's another thing, unilateral or bilateral. This is, if you look at the trial mostly did the bilateral surgery because they were doing it through the median sternotomy. But there are things to discuss here, whether to do bilateral or not, although there is no randomized comparison available for this. I am more in favor of the staged procedure, and the reason for this is because you want to prolong the benefit that you want to give to your patient. We know from the trial that the maximum benefit they achieve is for the first 2 to 3 years, and then gradually there is a bit of a decline, although sometimes it could go up to 4 years. So if you want to maximize the time period that the patient needs to benefit, then a staged procedure is better. Having said that, if your patient is really, really sick and you want to reduce your hospital stay, you want to, get a greater increase in FEV1, then yes, you could do, by all means, you could do a bilateral LVRS in the same sitting. But then in that option, as I said before, if you can do uniportal, it will be better. And if you can do subxiphoid, then, through the same incision, you can really resect both sides. People are doing it. It is, as I said before, it is doable. It's something which is achievable and may benefit this particular group of patients. Complications has got significant complications. The topmost is the air leak. This is the main trouble, and the main reason for this is the bad quality of the lungs, and the way you will handle the lung. And that's why I was saying, if you don't do this kind of operation routinely, if you don't feel like you are expert in this patient, please refer this patient to someone who know how to do this sort of surgery. The other complications are these patients are very likely to develop chest infections and pneumonia. They could even develop empyema because they can have a space problem there. Especially if they bleed for one or the other reason, then you are looking yourself into a difficult time. These patients may require some ventilatory support, and obviously mortality is something that you need to take into consideration, because there is a mortality of 5.5% at least in the high risk group, in the non-upper lobe predominant, in the upper lobe predominant group. And you need to use the techniques to avoid the air leak. That could be by using low ventilatory pressure during the anesthetic use. You can speak to your anesthetic colleagues. You can use the buttressed are the reinforced staple lines, so that the air leak is less. You can use some glues or spray on this once your lung has been reinflated, and check the air leak there and then, please. Your anesthetist will be able to tell you how much air leak they have got through the ventilator, and if it is significant, try to sort it out. Don't leave it there, because if you come out with this, it's not going to just settle itself. You may need to, then either go back or do something else, valves, or, be prepared for surgical emphysema and all those sort of things. Most of the surgeons actually, they say that with active suction, you're actually making the air leak worse. So they tend not to put the drains on suction, although again, the practice is variable, no hard and fast rules. Follow-up, yes, these patients needs to be seen. You can't just leave them after doing the surgery and go home. They need to have follow-up, and if you have LVRS program, 1, 6, 12 months follow-up is usually the standard. Assess them through the questionnaire which you gave them before the operation. Assess them again and do their physiological assessment through the measure of the PFTs. And now, if at later stage when they have symptoms again, if you have done unilateral LVRS, then they can potentially be considered for LVRS on the other side. NICE guidelines also mentions the LVRS for this. We have discussed these things. And here is the picture of the emphysema. And if you look onto your right-sided picture here, if you can see the cursor, this is a reasonable target in this X-ray. This seems more like a homogeneous. Now, when you talk about the NET trial, you also need to know something called WENT trial, which is an endobronchial valve for emphysema palliation trial. This was conducted after the NET trial, but the inclusion and exclusion criteria was sort of quite similar. As you can see, the FEV1, is between 15 or 45. There it was 20%. TLC, residual volume, and the 6-minute walk test and the gases are similar. And the exclusion or contraindications are quite similar as well. And here, in addition, you've got a joint bulla and alpha-1 antitrypsin deficiency. These patients were also divided into 2 groups, one with the endobronchial valve. The ratio of these group selection was 2:1. Here, you can see endobronchial valve, 220 patients, and group 2 had standard medical therapy, 110 patients. And for those who underwent the endobronchial valve insertions, the study demonstrated the improved FEV1, which was 6.8% mean with significant p-value. Okay, and they also saw the improved 6-minute walk test and 5.8% against the medical therapy. But having said that, they did have some complications, especially the increased risk of infective exacerbation of the COPD, which led to the hospitalization. This was about 7% against the medical treatment, which only had 1%. And they also have a risk of hemoptysis, which with medical therapy you don't. So here again, the patients with greater radiological evidence of emphysema heterogeneity and facial completeness showed the enhanced response to the treatment. Okay, and these bronchoscopic interventions, as we discussed before, they could be carried out by the endobronchial valves, by the coils, by the plugs, by extra anatomic injections, and the bypass. This is the valves here, which is the one-way valve. It lets the air come out, but doesn't let the air go in. Okay, and this is the coil here. And this is the exhale valve, which is used in extra anatomic bypass. But when you do this endobronchial valve, you need to assess collateral ventilation first. This collateral ventilation could be assessed preoperatively through the high-resolution CT. You will see completeness of the fissure. These patients usually have a high-resolution CT scan, so it is obvious you can get a good assessment from there. But preoperatively, there is also another phenomena an analysis which is called a StratX. It is offered by these companies who make the valves, the pulmonx valve. You send them the HRCT and they do it for you. And then operatively during the intervention, you could do a specific assessment, which is called the Chartis assessment. That again basically assesses the completeness, not the, well, it demonstrates the completeness of, so basically assesses the ventilation through the Chartis assessment. They have got the transducer, so they measure the pressure flow, which tell you about the ventilation. The endobronchial valves are deployed under the direct vision through the bronchoscopic intervention, and this could be in the lobar segment, it could be in the segments, and this could be sub-segments, this could be multiple segments. You could put as many as you want, depending on where your target areas are. Usually the flexible bronchoscope is used. You need to have probably larger working channels, so you can deploy the valves as well. But before the valve deployment, as I said, collateral ventilation needs to be assessed through the Chartis, which also not only assesses through the transducer the airflow, but you can also assess the diameter of the bronchus, because the segmental bronchus is a different diameter as compared to the further proximal bronchus. So you need to have a sizing of the valve as well, and choose the appropriate valve. We've gone too far, I think, in terms of timing. This was again a scheme and video of showing how you do the Chartis assessment, because it's mostly done by the pulmonologist. I'm going to leave it. These patients also are at risk of developing complications, like pneumothorax is the most common one, and that pneumothorax could lead to lung collapse or surgical emphysema. And valve displacement is another thing which you may have come across. Now, the last thing, when all these things fail, or sometimes even prior to failure of these treatments, these patients could be referred and considered for a lung transplant. Emphysema and COPD makes them one of the common indications for the lung transplant. And although both the COPD and emphysema are progressive, but patients may remain stable for many years. So in these patients, you can do optimization, but you could potentially do the early referral as well if you have a lung transplant center. The lung transplant assessment is done through our transplant physician, then through the surgeons. There are criteria including the Bode index, and these are the patients who are, I will show you what the Bode index is on the next slide, but these are the patients who are requiring frequent hospitalization because they're hypercapnic and they're struggling, and they have got very, very poor PFTs. Their diffusion capacity is less than 20%. Their FEV1 is less than 20%. Now, these patients will definitely need to be referred, but that doesn't mean that you only refer for lung transplant at this stage. You could, if they are functionally not that good, you need to make earlier referral. And this would be for all emphysema. Homogeneous emphysema, and even if patients have secondary pulmonary hypertension, they could be considered for transplant, although they may need heart-lung block. This is the Bode index for the people who will be sitting for the exam. Basically, this is a very simple thing, which includes the body mass index, the FEV1 6-minute walk test, and the dyspnea scale. The more severe the symptoms you are, the higher the score is. That means you need to be referred for the transplant assessment. That's what it says. Okay, I think that's it from me for today. Thank you.
Hey, thank you very much, Mr. Nawaz. Fantastic lecture, absolutely crisp and clear concepts. Really, really loved it, actually. So I'm going to leave the floor open for people who want to ask questions. Before we do that, I'll just sort of highlight what is needed for the exam. He has very clearly sort of gone through everything. So I'll just tell you what questions come in the exam. So the first and foremost question is indication for LVRS. And that slide, you must know it inside out. I mean, if I wake you up from sleep, you must be able to tell me straight away. Okay, so number one is indications for LVRS. Number two is optimization of a patient with LVRS. So my suggestion is you write down these points and then go through this lecture again so that you highlight these points. Number three, surgical approach is quite standard. It's okay. He's very clearly said about bilateral approach versus unilateral approach. He's very nicely spoken about median sternotomy, thoracotomy, and VATS. And nowadays, the newer controversy is uniportal versus multiportal VATS. In the exam, I would not venture into the robotic platform just as yet, because there's not enough data to support the robotic platform. I personally do the LVRS by robotics, but I personally feel that there is not enough data for you to justify your approach by robotics in the exam for sure. Because there are two issues. There are two issues with robotics. One is that there are multiple ports being used as opposed to a uniportal VATS. And the second issue is the cost effectiveness of the surgery. Not about the robotic platform. It's not about the cost effectiveness because of the robotic platform. This is an expensive surgery because you end up using about 10 to 16 staplers. That is the key thing. So, you know, when you go around in a horseshoe pattern, you can anywhere between 8 to 16 staplers are needed. And these are pledgeted staplers that you use. So the cost of the stapler is pretty high. And then when you add a robotic platform, the cost goes up. And then when you add a robotic stapler on the robotic platform, rather than using a laparoscopic stapler, the cost significantly goes higher. So just at this moment, I would advise everybody not to talk about robotics at all on the LVRS platform. It is all experimental. All of us are doing it purely because we love the robotic platform, but there is absolutely no shred of evidence at the moment to support that. So that's a very, very good discussion. I think I like the fact that Asghar very clearly suggested, though all of the NET trial was on bilateral patients. Really, nowadays, most of us go unilateral staged approach. So you do one side first and then, you know, do it in a staged manner. So that way you prolong the benefit for the patient. Because really, at the end of the day, if you look at all the trials, the problem with all of the LVRS surgery is that you get the maximum improvement in the first year. But if you look at 5 years and if you look at 10 years, you're back down. There is a slow slope down and you're back to stage one, what you were before. So this is, you're not treating the disease. The disease is there. The lung is destroyed. All you're doing is improving symptoms for the patient. So please get this concept very clear. So when you read the NET trial, please look at the data of 5 years outcomes, and you will find that over 5 years, all the numbers start to decline again. So the FEV1 improvement, which we get right at the start, actually declines over 5 years. And that data is out there. There are graphs, and I've got the graphs. If you want, I can show it to you. So that's important to remember. That's why the staged approach is better, because then you do one side, and then if over 4 or 5 years, you find that the patient has declined in his symptoms and it's starting to become worse, then you still got the other side to offer to the patient. Otherwise, the next step, once you've done bilateral straight away, the next step is only lung transplant. There is no other way out. But the problem is, again, with lung transplant is that if you've wasted 5-7 years with a bilateral LVRS, then you are become an older patient for lung transplant. So it's like a catch-22. You're sort of, you might miss the boat for lung transplant because you've had an LVRS and you've got 5-10 years of benefit. So that's the way you have to sort of work it out. Complications were beautifully covered. I think very nice. I love the concept of techniques to reduce post-operative air leak is quite important. And the techniques of reducing post-operative air leak, his slides were very, very clear. Most important technique is intra-op, okay, not post-op. The most important technique is intra-op, on table, use of a buttress stapling, checking the air leak on table, use of piss seal or taco seal or any sealant on table is the key to improve the technique. And of course, the no-touch technique. So he's handling the lung very carefully, and he's making sure that he's not handling the lung which is left behind, but handling the lung that is coming out. And then post-operatively, the non-use of suction. That is key thing. So non-use of ventilation and non-use of suction is a very, very important point. Asghar, don't mind. I'm just summarizing all these important points for the exam going people. Because these are the points which I think we ask in the exam quite often. Then, of course, you spoke about vent trial. So you need to know findings of net trial, and you do need to know findings of vent trial. These are the two classic questions we will ask you. The one thing he made very clear was this is the best patients who get benefit are upper lobe emphysema with low exercise capacity. So the philosophy is the patient must earn the surgery. The worse the patient, the better the outcome. Do not do a patient who's got marginal capacity. Okay, like he can walk 4 flights of stairs. He's not the guy. If the guy is wheelchair bound, that is the guy you want to do LVRS on. So worse the symptom, better are the outcomes with LVRS. And of course, do not forget the upper lobe preponderance and heterogeneous. That is the key thing. And all data has looked at that. So I think, thank you very much, Asghar. One question which we frequently ask in the exam, which I didn't see on the slides, which is a common sense answer, but we frequently ask, tell us what happens to the PFTs in an LVRS patient. So, a frequent question I ask is, which number goes up and which number goes down? Okay, and actually, I don't need to share the slides. I'll just tell you what happens. Because if you don't think carefully, and if it's not clear in your mind, you might not be able to answer in the exam straight away. So the 3 numbers which improve when we do LVRS, number 1 is vital capacity, number 2 is FEV1, and number 3 is FVC, and number 4 is DLCO. So write this down. So if I ask you straight away, what is the improvement on the lung functions directly following LVRS surgeries, you must give me these 4 numbers. FEV1 increases, the FVC increases, the vital capacity increases, and the DLCO increases. So these 4 increase, and 2 things reduce. One is the residual volume, and the next thing is the total lung capacity. The TLC goes down.
Okay? If you want to show them picture, I've actually stopped sharing screen, so you can show them the graph.
Yeah, it's okay. It's all right. Don't worry. They've got the concept. It's just, you've understood the concept. We're taking away a curve of the thing. Let me share my screen if you want. I'll just share my screen. So here we are. So it's just for you to know these things, okay? It is quite important that the TLC goes down, the residual volume goes down. This is a common question we will ask you in the exam. And unfortunately, if you have not thought about it, you may not be able to reproduce it. The next thing is, can you see my slide? The vital capacity goes up, the FEV1 goes up, the FVC goes up, and the DLCO goes up, okay? These are the few things that you need to remember. So whenever you talk about LVRS, you must know what are the numbers which improve and what are the numbers which reduce. And then he has shown the graphs beautifully. I really thought you went through the graphs very, very well, and you showed all the graphs pretty well. I just want to show you, once again, I'll share my screen because we spoke about 5 years, what happens. And let me just start sharing my screen with you. And I will share my desktop 2, desktop 1 actually. Just 1 second, please. So this is the 5-year thing that you must know. So at 5 years, everything goes down. Can you see that? So first is the survival goes down almost 33% at 5 years. The next is the quality of life according to the SF36 goes down. The dyspnea scale goes down because initially at 6 months you've got a lot of improvement, but over a period of time it has gone down at 5 years. And the FEV1 also goes down. So initially, immediately after the surgery, you've got very good improvement in FEV1. But if you look over a period of time, the FEV1 goes down. And the other important thing is, as I told you, the FEV1 goes down is the chart on the top. The FEV1 is improved initially, but goes down over 5 years. The FVC is improved initially, but goes down over 5 years. Okay. And the next point, which I told you, is that the residual volume decreases initially, but over 5 years, it will come back to normal. And the TLC will also decrease. But again, with the disease process progressing, it will come back to the baseline. So that is the other thing. And the most important benefit that you get is the shuttle walk. Yes, this distance increases immediately after surgery, but over a period of time, it goes down. So it is not just immediately after surgery, but you've also got to talk at what happens at 5 years. So this is how the analysis is done. And then the rest of the slides is shown beautifully. So let me just stop sharing the thing. Sorry, 1 second. Okay, any questions that you want to ask? Asghar, are you okay? Do you want to make any comments on what I just said?
No, I actually fully agree. I think, yes, I should have included the 5-year survival as well. But
that's all right.
we discussed that, the maximum benefit you could see is, is 2 to 3 years. And after that, you gradually see the decline. And that's why we said, do a staged procedure.
Yeah, the problem is in the exam, you get asked these questions, Asghar. That's why I specifically highlighted these few points.
Yeah.
As I was following a lecture very closely, so I was listening.
One thing I would actually tell is more for the people who would be sitting for the exam is actually I had a case myself, and so when I had my FRCS, I went for the long case, not short case. The long case I went in, and they said to me, "This is your patient. He has got a history of pneumothorax. Take history and examination, all yours." And I thought, really, for FRCS pneumothorax? But interesting. I said, okay, fine. It kind of did give me, I'm going to either get something bad or, this is very simple. And sometimes you actually fail on simple things. And in whole cardiothoracic surgery exam, I was flying through the cardiac bed, thoracic bed. I personally felt it was more difficult because thoracic is quite wider and there's a lot of discussion that you can do. So when I examined the patient, in addition to the pneumothorax history, I found out that he's got a pectus as well. I said, okay, well, fine. I reviewed some things that it could be asked for pectus surgery. And then my examiner said, very nice. So you have taken the history, you've done the good examination, we're happy for you. What do you want to do now? And I said, I want to see some imaging. Could I have a look onto the CT scan? And then they showed me the CT scan. And that's where the whole thing started. And that's my next point, which I could have potentially mentioned in my slide for discussion, but I think we can discuss now. And that was that we found the patient has got this bully at the apex, plus he has got some speculated lesion onto the contralateral side. And that's where then the discussion started. You have got a case who has got a recurrent pneumothorax, it's got pectus, which was not significant, not bothering the patient, but you have got a lesion on the contralateral side. And all the discussions around which to manage first, how to deal with one while you are looking after the other thing. So you're going to deal with something which is going to kill the patient first. So, assess what the quality of the lung was, and then at the same time, how strongly there is a suspicion for that lesion to be malignant. Say, for example, if he's a heavy smoker, he's a relatively higher end of the age. If he has a history of cancer himself or family, if he has got industrial exposure, and if he has got a high Brock model or the picture, the speculated lesion, and if you have done the PET scan, then if there's a high uptake. So all these things count then. And then if, say for example, if you're going to go first for the lung surgery, how would you manage, because he has got a history of recurrent pneumothorax, and what risk he would be and how would you manage? So that is a separate discussion. But what I was going to say, let's leave that for a minute, although it is interesting. But let's leave that. You find a patient who's got a upper lobe predominant emphysema, which you were not aware of. Patient has been referred to you by chest physician for lung cancer suspicious lesion, or even if it is diagnosed, but let's keep it suspicious lesion on the left upper lobe of the lung. You did the lung function test. Lung function tests were borderline, and but you found there was some upper lobe predominant heterogeneous emphysema. What will you do? The problem on this is, you know the answer, but I don't know, because our audience is not able to interact with me. It would have been interesting if someone knew whether they will offer surgery to this patient or not.
Well, they can actually interact with you. So if you want to ask the question again, go ahead. Everybody's mic can be on. I will point out people. So just come back again with the question. I missed that. Sorry.
So you are in the exam, and you have been referred a patient who is 65-year-old who has a history of smoking, and he has got a stage 1 T1B N0 M0. Let's say he has got a biopsy as well. T1B N0 M0 adenocarcinoma left upper lobe of the lung. He feels short of breath on doing the stairs, and his FEV1 is 48%. Let's say 50%. FEV1 is 50%, DLCO is the 50% as well. What would you do? Would you offer him surgery, or would you not offer him surgery? Is anyone who wants to, among the audience, who want to come forward and have a discussion?
Okay, let's have this discussion. Let's get in. Let me see who's on here. Is Anurag with us? Anurag, do you want to come in? Or Nikhil, you want to come in? Nikhil, are you with us?
Yes, I am with you, sir.
Okay, so just listen to the question and tell us what you think about it. Do you want to operate on this patient?
Sir, need to find out the cause of decreased FEV1 and DLCO.
So he's got a heterogeneous, he's a smoker, and he's got a heterogeneous emphysema.
I like to do a ventilation perfusion scan to see the how much lung parenchyma can be salvaged, and if along with the lung cancer surgery, whether the LVRS can be possible. Because T1B lesion is a potentially operable lesion.
Yes, you're right.
As the and the clinical scenario as given N0 M0. So is a no doubt there is a surgery has a beneficial role if the associated disease can be tackled at the same time.
So what would you do? Would you offer him surgery? He's got borderline lung function test. You do your assessment on the last time. I don't know whether you were, you see the patient, and then you also see how he will be once you have done the lung resection. So if this patient has got FEV1 and DLCO of 50%, so you will calculate your post resection. So if you're going to remove the left upper lobe, So he's gonna be sitting around probably 40% post-op, roughly.
Yeah. I like.
Would you offer him surgery?
Can we do a CPET first?
Yes, you did the PET scan. Oh, you mean the CPEX? Okay, cardiopulmonary exercise.
Yeah.
Okay, well, that's a good way of doing it. His CPEX is okay. His borderline. He's got VO2 of 15.
I like to still go ahead with 6-meter walk test and 22 meters climbing, stair climbing.
Okay, Nikhil, okay.
Because potentially operable, I'll find out every reason to get him on a table. But if he's
Nikhil, don't dodge the question. Just give an answer, man. Give a definite answer. Don't dodge the question. I'm okay with you saying the other points. You've done a CPEX. His VO2 max is more than 15. Now, what are you going to do? Do you want to operate or not? Just say yes or no.
Yes.
You want to operate. Okay. All right. Asghar, what's your take on this?
Yeah. So I would, Nikhil, I would operate on this because, you know, from today's topic, firstly, the patients, you know, lung function tests are important, and make sure patient, the most important thing than the lung function is the patient assessment, because the lung functions could be sometimes, you know, if you get if you are working in India, say, for example, and you get someone from the south part of the India who is not good at speaking at Hindi, they will be good at some other languages, then, you know, they may not your PFTs may not be true reflective of what, but the performance status is the most important thing. So when you calculate, so the whole thing I wanted to say is usually your FEV1 post-op, post-resection, if it is around 40% or above is okay, although 40% or below is considered risky. But in patient, I wanted to give the stress on this particular patient. This patient has got heterogeneous upper lobe emphysema where the lung cancer is sitting. Yeah, I said the lesion is the left upper lobe as well, and he's got a left upper lobe emphysema. So you may actually functionally not only benefit him by removing the cancer, you may actually make his breathing potentially better.
Yes, sir. This I didn't thought.
So Nikhil, you are absolutely right in your answer, but what you lacked is the confidence to give the answer. So it's a very, very good point which Asghar has made, and I love the way you took the answer, Nikhil. Very good, well done. But have the confidence to say that in the exam, that I am going to operate on this patient. I'm happy with you asking for a CPAT, but most of the people on this group will also try to dodge the question, thinking that there is a googly in there. Actually, there was no googly. He was very clear. The lesion is in the left upper lobe. The emphysema is in the left upper lobe. Do a left upper lobectomy, and you have a dual benefit for the patient. Yeah. So very well done, Nikhil. But just have the confidence to give the answer in the exam. Okay. Yes, you are absolutely right. There's nothing wrong with what you're saying. But what we like to see is you being confident about giving that answer. Okay. Yes. So well done to everybody actually. So yes, Asghar, tell us.
Yeah, so this, you know, you may come across these kind of situations when you may have, you know, patients who are high risk coming to you. And actually, to be honest, in selective cases, we have offered surgery to the people whose predicted post-op was less than 40%, but who came with these kind of features. Although, as I said, you know, you have to consider overall picture of the patient, not just one.
So, Asghar, for the benefit of the audience, I'm going to ask you a question, if that's okay with you. The question is, in that case which you described earlier with the pneumothorax and the emphysema changes, what did you do about the pectus? What answer did you give for pectus?
So actually, in that particular patient, the pectus was not, as I said during the pectus was not significant at all, and patient said wasn't bothered about the pectus at all. So most of the conversation from the examiner and from the patient was around how we manage this patient, because which one you're going to treat first. So what we were discussing is, we're going to treat the first, which is going to kill the patient first. So if it is the pneumothorax which is going to kill the patient first, then we treat the pneumothorax first. But if it is, the lung cancer, then we do the lung cancer. But at the same time, we have to, when we are doing the lung cancer, say for example, if we are going to, if we are happy that this is suspicious lesion and needs further investigation while patient is fit and we have a chance to operate on him, we can do for the pneumothorax. But if this is the lung cancer that needs attention first, then what we need to do is we need to be able to manage this patient accordingly. We need to have in mind that when he goes on the operating theater table, he had previous pneumothorax with the single lung ventilation. Now that lung will be under in the whole lung where the all the ventilation will be coming from, and he is more likely to develop pneumothorax in the presence of positive pressure. So then looking at the quality of the lung, either you can put a chest drain prior to the operation, or unless if you're fully confident, that this patient is unlikely to have this kind of effect, or I'll be able to manage, you have convinced your anesthetist, or your anesthetist is convinced that you are all happy, still keep in mind that intraoperatively, he may, if his oxygen saturation drop, if there's a difficulty in ventilation, you may need to decompress and put a chest drain in. But ideally, if he has got recurrent pneumothorax, be prepared when you're putting on single lung ventilation. Before go on positive pressure, put a chest drain in and manage that way if your lung cancer need attention first.
Yeah, just for the youngsters on the group who are listening in, if I'm ever faced with a situation like this, the one thing that I would not treat, not treat, is the pectus, because I would be putting a bar across the chest. And the last thing I want to do is put in a foreign body into a pleural space, which might have had a chest drain in the past. So please be very clear about your concepts. Number one, he said it's mild, so he didn't treat it, which was fine. But even if it was more, I would not put in a foreign body across the sternum into the pleural space, which potentially has had a chest drain in the past, because that is a strictly no. You will end up with trouble in that situation. Vikas, can you just you had a question to ask?
Yes, sir. Sir.
Asghar, are you okay for time? Is that all right? Or
Yeah, it's okay. It's okay.
You're okay? Thank you. Yeah. Vikas, what's your question? Come in, Vikas. Your sound is not over.
He is muted.
Yeah, you're muted. Switch on your microphone, Vikas. You've got two devices, so I think one device. Yeah, that's good.
Yeah. So if in this patient where there was a problem on one side and emphysema also on the same side, if the emphysema was on other side, how would we go about it? Will we do it in the same sitting or one after other? Right side node, T1B node, and left side emphysema.
Okay. Yeah, Asghar, you give the answer. For me, the answer is very clear.
So if he came for the lung cancer surgery, you just focus on that, because he's got no active issue from there. If he is fit,
Absolutely.
if he is fit for surgery, you just go and address your lung cancer.
Yeah, the two things you've got to remember. One is as Asghar said before, what is going to kill him, and that is the lung cancer. So you operate only on one side. Bilateral surgery is not good for patients. I promise you, even if you do it by VATS, uniportal VATS, multi-port VATS, anything, bilateral surgery is not well tolerated by patients. So I would not jump into the right side at all. But the one answer I will give in the exam is I will have a intercostal chest drain ready during induction of anesthesia. In case the patient gets compromised, I will jump in and put in a chest drain. Because when you start him on positive pressure ventilation, and when you go on single lung ventilation, there is a potential risk of creating a pneumothorax on the opposite side. But all you would do is put in a chest drain for that pneumothorax. So that is what I would say. But I would say I will keep a standby ICD tray insertion kit ready, and I would be scrubbed and in my gown before the induction starts. So this is how we assess you, whether you are a safe surgeon or not. So you will never give this guy anesthesia without somebody being ready to jump in and make a quick incision and put in a chest tray, because you'll quickly end up with a tension. So that's why you have to say this answer. But you would not operate on the right side. Absolutely correct. The one thing that I would again advise all of you in this scenario, in the current evidence that is available, do not, and again I'm clarifying, do not jump in to the uniportal versus multiport discussion. Do not. There is not enough evidence. Okay, you will not be able to justify your statements one way or the other. So you just say whatever you're comfortable with, but don't go into the uniportal versus multiport discussion just as yet, because there is really no randomized control study which has looked at one versus the other. And in an exam, you need to be safe. And chances are your examiner will be a senior guy. And chances are if he's doing VATS, he'll be doing multiport rather than single port. So do not get into that argument. It's a dangerous ground to upset somebody. So I completely agree with Asghar's concepts where he's saying uniportal LVRS is great. And I am quite happy with that. But in an exam, I would not jump into that discussion because there is no evidence to show that the pain is less by uniportal as compared to multiport. So at least for now, maybe in a few years we'll be in a better position, but at least for now, don't get into that discussion. Okay. All right. Are you okay with that, Asghar, or do you?
No, because in the
you
exam,
must talk about uniportal.
Yeah, no, the exam, basically exam approach is a different, practical approach to the patient is different. What you could say if someone is, has scored high from the discussion and that he ended up going to discussion of the superiority of one technique over the other and the randomized controlled trials, it means that candidate has actually done really well in terms of his progress. Sure. Or if he hasn't progressed and the trials are asked within the first 2 minutes, then it also means that he has done really bad as well. If the discussion goes within 2 minutes to the trial. So remember these two. If the discussion goes to the randomized trials and the superiority of any technique, that comes at the end. But during the presentation, I was saying it again and again, there are certain things which are preference, and I also told the reasons for the preference for those as well. Uniportal, now there are certain concepts which are extracted, from one thing. Say, for example, initially there were discussions and studies and the trials for which is superior or which is safe. Actually, if we say studies were done to say whether VATS were actually safe or not. When VATS has proven that it is safe, then people who do minimal axial surgery, then they also started to say, or their extraction or conclusion from this was, because the VATS has proven to be safe, then it means thoracotomy needs to be stopped for those cases which are suitable for. But these are the discussions. You just need to be aware of that, but don't go strictly, don't jump onto one particular thing, because these are very specialized technique. Only very few people are trained into these. You just say what are common. During my presentation, I showed that in 2011, there were about 41% of cases which had LVRS through the thoracotomy sternotomy. So which is a large number. So what we need to say in the exam, and as Mr. Khan very rightly said, the examiner is more likely to be not me. It will be person who is more experienced person. So that's why you need to give answer accordingly.
Absolutely correct. Yeah, Vikas, you still got your hand up. Is there another question you've got?
No, sir. No, sir.
Okay, all right. Anybody else has got any more questions? I think this topic has been beautifully covered. I'm really happy with the way we've gone around this. So I think we will call it to a close. Asghar, thank you very much for taking so much time out from your busy schedule and helping to enlighten our students. I'm very sure that this video, which gets recorded, will be looked at again and again for forever. I think people, before going to their exams, will look at this video again and again, and it will help them revise for their FRCS examination. So thank you very much. We really appreciate your time and effort for the benefit of our students. And thank you to all the students for taking time out and attending these lectures. We cannot do it until and unless you guys give us the feedback to say that you're benefiting from it. As Asghar said right at the start, that unless and until he gets a feedback, he cannot. It does not encourage him to make the next presentation. So
yeah. No,
so
thank you very much. Thank you very much. And yes, feedback is important, because sometimes what I might be saying, or any other who is delivering a lecture, or Mr. Khan, we might be saying what we think is right, but there may be some certain things, because we are doing it for your benefit. So if you tell us what something if needs to be excluded or something needs more attention, then we can work on those bits. So it's more benefit to you.
Okay, thank you very much, and good night to everybody, and have a safe day and a safe life. Really, with the COVID, we've all got to stay safe and take protections.
Yeah, sure.
Okay,
Thank you.
Thank you very